Welcome to the Australian Prescriber Podcast. Australian Prescriber, independent, peer-reviewed and free.
Hi, I'm Dr. Justin Coleman, a GP from Brisbane, and with me I have Professor Jeff Isbister, a clinical toxicologist from the University of Newcastle. Welcome, Jeff.
Hi, how's it going?
Very well. Jeff, you seem to have developed a passion for little critters that sting, bite, and quite frankly have the potential to make our lives a misery. What is this strange attraction you have to things that send most of us running for the door or for a hardy broomstick?
To be honest, I don't have a good answer. I mean, a lot of people would say, oh, did I grow up collecting snakes or spiders? And I certainly don't go anywhere near snakes. I think my interest came from the fact that bites and stings can cause systemic effects from all systems. You're not a specialist in one. You get the whole range of things, which makes it far more interesting.
You should have been a general practitioner, Jeff. You've developed quite a rep as a mythbuster over the years, so I thought we'd start with spiders and work our way up in size, or if you prefer, work our way down in number of legs. And the first I heard of your work was when you debunked the myth that those mysterious necrotic skin ulcers are due to the bite of a white-tailed spider. What happened there?
So spiders have been blamed for many things. And towards the end of my research on that, I discovered even the Great Plague was blamed on spiders. And I think it's a fear of this eight-legged creature. And also when people see a doctor, if they've got something wrong with them, often they want a reason for it, an external cause. And spiders were a great thing for it. And in Australia in the early 80s, people started developing different varied necrotic ulcers, and they were blamed on the white-tailed spider. And that was really because someone went back to a house where these people were and found white-tailed spiders in the house. The problem is that in eastern and southern Australia, every second house has a white-tailed spider in it. And from then, this myth just grew. So when I started doing my research, I worked in Sydney. I wasn't near the coast, and I wanted to do bites and stings. So there was no snakes, there was no marine things. So I thought, all I can do is spiders. So I started just taking calls from the poison centre where we got definite cases. And over a 2-year period, I collected people who had been bitten by a spider who collected it. They then posted it to me. I became very unpopular at the hospital I was working at as we had all these spiders arriving in the mail.
And with all the Australia Post posties, I would imagine wouldn't have been too happy.
Well, yeah, that's right. I found out after I did it that it's not actually illegal to send spiders. It's illegal to send snakes, bees and scorpions by post. So I was okay with spiders. And then what I essentially did was a study. It was, here's a definite bite. I got a arachnologist at the Australian Museum, Mike Gray, identified all of these spiders I collected. And we just correlated definite bites with definite clinical effects. And of 130 white-tailed spider bites, we had a whole lot of people had a bit of pain, red spot, and nothing more than that. So it didn't cause these necrotic ulcers. In a reverse study, we had people being referred to us because at that stage, I was working in a toxicology unit. We got ulcers referred to us, and in every single case, we could find another cause. And I learned a lot about weird infections and dermatological things I'd never heard of that can cause ulcers.
I was so hoping you would tell me the reverse study was having people deliberately bitten by white-tailed spiders, but perhaps that research is in the future. You then tackled that great Aussie icon, the redback on the toilet seat, and magnificently named your work the Redback Antivenom Evaluation Study, or RAVE, which for me conjured up images of what toxicologists get up to after hours in the lab. And this study compared different delivery mechanisms for redback spider antivenom. And what did you find there?
So I can't take credit for RAVE. That was one of the other investigators. I'm not very good at acronyms. Okay. Great acronym. So what we did is we looked at intramuscular versus intravenous because we found that people weren't responding that well. There was case reports, give IM, then gave IB, and they got dramatically better. So we compared them in a randomized controlled trial and showed that they were the same, despite really wanting IV to be better because that made sense. Problem with that is that we showed that they were either both equally effective or equally ineffective is what we then became concerned about because we measured antivenom in patients, and when you gave it IV, you could detect it in blood, but not when you gave it intramuscularly. So that gave us clinical equipoise and the ethical ability to do the placebo randomized controlled trial, which we finished and was published more recently and showed that antivenom is no better than just pain relief alone for redback spider bites.
You're doing magnificently well for this natural skeptic. 2 out of 2 so far. Let me ask you a quick true or false, Jeff, keep you on your toes. If you get bitten by a radioactive spider, can you learn to climb up the outside of buildings?
I've never tried it. I don't know the answer to that, but I think the answer is probably false in the real world, unless you're watching Spider-Man.
Okay. I wouldn't want to be part of that trial, I guess. I wouldn't ever need to use the stairs again, but it could be a bit dangerous. While we're still at the 8-leg level of this conversation, let's talk about scorpions. Are bites common in Australia from scorpions? And if so, how does the treatment differ from spider bites?
I would say they're uncommon to rare. They certainly occur. When I started doing a study, I was surprised that we even had scorpions. There are lots and lots of scorpions in Australia if you know how to look for them, but not as many stings. So I think over about a 2-year period to the Poison Centre, we got about 100 cases. And essentially they cause pain, probably a lot more pain than a spider bite, but really it lasts 4 to 6 hours and then it goes. Most importantly, we don't have scorpions that cause severe systemic toxicity, and worldwide, scorpions after snakes are the largest cause of severe morbidity and mortality from bites and stings.
Thank you. I'm talking to Jeff Isbister, a 2-legged clinical toxicologist from Newcastle. On to snakes now. And much of your research has actually resulted in less antivenom being used rather than more. And I'm guessing that milking a snake's fangs is considerably more fraught than milking a cow. But there was one point in time where we used to continually deliver antivenom over the course of treating a snake bite. And we went through our antivenom stocks at a great rate and probably harmed patients in the process. But you're a part of changing that?
I mean, when I trained, that was what you did. You kept doing blood tests in particular coagulation studies, and every time they were abnormal, you gave more antivenom, because if they weren't better, then clearly you needed to give more treatment. But what we've shown since then, and I mean, you look back and think it's completely obvious, the type of coagulopathy, which we call venom-induced consumption coagulopathy in most snake bites in Australia, and is probably 80% of what we're dealing with Australian snake bite, is a consumptive coagulopathy. So it's a factor deficiency. It's like someone with haemophilia. So even if you give antivenom and stop the toxin doing its damage, which it does very rapidly, it's not going to get better until you make more factors. Your liver synthesizes more factors. It doesn't matter how much antivenom you give, you aren't going to get more factors until you just wait that time. So what it really is about, and we knew it for neurotoxicity as well, is that many of the effects of snakes are irreversible. So giving antivenom once the effects have occurred isn't going to make the patient better. It'll stop them or prevent them getting worse. So now our focus is really on giving antivenom early to stop things happening, and more importantly, sort of neurotoxicity and muscle, so myotoxicity or rhabdomyolysis.
Okay, so if we have to give it early, so the patient comes in with a leg trussed up like a turkey after their first aid for snake bite, and we want to know whether they've been envenomated as opposed to just bitten. How accurate is our clinical history and examination versus clotting tests, that's presumably APTT, INR, versus any other test?
Answering your exact question is how accurate is clinical history versus the laboratory. The laboratory is 100% accurate, because if you've got venom-induced consumptive coagulopathy, it's defined by having completely abnormal, so an unrecordable INR and APTT.
Right.
However, that doesn't help. That tells you the patient's got it. The question you really want to ask is the clinical history early on, can we make the decision then? Because that's when we need to give the antivenom. We don't want a blood test that tells us, well, it's too late, you've already got those effects. Creatine kinase CK is another thing, is that once that goes up, well, you've got muscle damage. So you can be sure that it's there, but it doesn't help you with the antivenom. So now we are really moving to that initial period in the first, even 2 hours. And if patients do have clinical symptoms, so if they've got headache, nausea, vomiting, certainly myself, and encouraging people more to think, well, that really means that they're in venom, that they've got venom in their system. And if you give antivenom now, it's going to be the most effective that can be, so that later on when you do those blood tests, hopefully they're not going to be abnormal.
Very interesting. Thanks, Jeff. Look, we've done 8 legs and we've done no legs, but let's finish off with things that look like they probably have lots of legs, but you're probably going to tell me they don't have any, which is jellyfish and blue bottles and other submerged terrors of the shallows. You published some wonderfully pragmatic research in the MJA a decade ago called a randomized controlled trial of hot water at 45 degrees immersion versus ice packs for pain relief in blue bottle stings. So which one, the kettle or the freezer? And what have you done since with other jellyfish?
All the hard work was actually done by the emergency registrar who did this research project. He was the one who sat on the beach and collected these patients.
That's what registrars are for.
Well, yeah, they did the hard work. I said, it'd be a great study to do, but yeah, so we had to get council permission. We can only do it on Sundays when the volunteer lifesavers were there. We recruited, almost 100 patients. We recruited a third of them in one day because, as you know, the blue bottles come, everyone gets stung, and then you sit on the beach for the next 3 weeks doing nothing. So from that point of view, it was a difficult study. The other thing I liked about it is we showed that a treatment worked because I think one of my colleagues here calls me Dr. TN, therapeutic nihilist, because as you can see, prove antivenom doesn't work, prove this doesn't work, use less dose. At least with the blue bottles, we showed that hot water was clearly more effective than ice packs. So 20 minutes of either immersing a limb or even a shower if you can't do immersion will treat the pain of blue bottle stings in 90% of patients compared to what appeared to be more of a placebo effect with ice packs.
Okay, is that presumably because the toxin is designed for use in seawater and you do something to the proteins or something when you heat it up?
Yeah, that's exactly right. So there's in vitro studies that have shown if you heat the toxins up above 45 degrees, the proteins degrade, and so therefore they won't work. The problem is that you've got a very narrow range there because if you go over 50 and you expose someone for up to an hour, then you'll actually get a superficial burn, which has been what's made it harder to put this study into practice because you need your supply that does exactly the 45 degrees.
Okay, and you've recently extended that to box jellyfish.
Yeah.
What's the story there?
So we looked at box jellyfish, but we looked at it in the emergency department at Royal Darwin Hospital, and we showed there was no difference between the hot water and ice packs. And that was an unusual finding. And I think the difference is those patients were being treated after they'd been picked up from where they'd been stung by ambulance, come to the emergency department, and there was quite a delay. And we think that that's why it wasn't as effective. You've waited too long. Whereas off the beach with blue bottle stings, people were getting treated within, 5 minutes of their sting. The one thing is we think that you need to give it earlier for box jellyfish stings, much more difficult study to do in the future. But in terms of emergency, like in hospital management, clearly hot water was no more effective than ice packs. Ice packs are easier to use. So even though it's probably a placebo effect, that's still the current recommendation for it.
Very interesting. I take it we save the vinegar for the fish and chips still.
Oh, so the vinegar's different. Although it has become a bit controversial in the last few years, vinegar is designed to essentially stop nematocysts, like more toxin getting in. So it's not about pain. As you can imagine, if you've got a sting on and you pour vinegar over it, it will make the pain much worse. It's about stopping, for box jellyfish, severe life-threatening envenoming. So it's definitely not recommended for blue bottles because it'll just make the pain worse. It's recommended for jellyfish where you're trying to stop systemic envenoming.
Oh, very interesting. That's all we've got time for. So thank you very much, Dr. Jeff Isbister, and thanks for spending your time educating us at Australian Prescriber. I'm Dr. Justin Coleman, and you'll hear again from me soon.
Thanks.
Over the years, Jeff Isbister has written articles on spiders, snakes and stinging thingies, available online at nps.org.au/Australian Prescriber. And like our whole journal, it won't cost you a brass razoo. Subscribe and we'll deliver ourselves straight to your inbox, or follow us on Twitter at AustPrescriber. The guest's views are his own, not NPS's, and I just make up things as I go. I also host the GP Skeptics podcast series. Google GP Skeptics or my name. I'm Dr. Justin Coleman. Thanks for listening to another Australian Prescriber podcast.